are the insurance guidelines for 2020. Actually, I pulled these from United Healthcare, and this is what they require for ablation, to approve for a treatment for venous insufficiency. The greater saphenous vein must be 5.5 millimeters or greater when measured at the proximal thigh immediately below the saphenous femoral junction. So we need to find the greater, that's why it's so important to get the greatest diameter of the saphenous vein. And then the small saphenous vein, if they wanted to treat the small saphenous vein or an accessory vein of the small saphenous, must be measured 5 millimeters or greater in diameter below the appropriate junction. And then our reflex, very similar to the diagnostic criteria that we just discussed. I think it's the same actually, yep, 500 milliseconds, greater than or equal to 500 milliseconds for the greater saphenous and the short saphenous, or even the principal tributaries. And then our perforating veins at 350 milliseconds. So, yes.
Before we get into treatment, I'm going to have you answer a couple of questions that have come in with regards to the exam.
Okay.
Were there any methods for scanning obese patients or patients that are in a coma?
For obese patients, we definitely, the obese patient population has problems with increased venous pressure and develops chronic venous insufficiency, problems associated with venous insufficiency. So we definitely scan these patients. I try to use the linear probe, certainly, because that's the best vascular probe, but if we have to use a curved probe to penetrate, then we will. The augmentation, it's still effective. It's still effective. The proximal compression or the distal augmentation approach is effective. The Valsalva often is not effective. So with the obese patient population, I might have to actually, when I'm stressing the valves in the groin, I might actually just have to compress just proximal to my probe instead of in the abdomen or in the pelvic region, just because of depending on the size of the pannus and the size of the patient. But we can still do AP diameter measurements. We can still assess for reflux. We can still evaluate for varicose veins and find them and follow them. It's still a valuable study, and we can still find evidence of disease and help them.
Thank you. What about for patients in a coma?
Oh yes, for patients in a coma, it would be proximal compression to stress those valves. It would be proximal compression, proximal to the probe where you need to evaluate.
Great. There's a couple more questions with regards to the protocol. Do you palpate areas of interest that you have the patient point to?
Do I touch it? Yeah.
Yeah, palpate them.
Yeah.
Okay. And then how exactly do you measure the vein diameter? Is it leading edge to leading edge or outside to outside? What's the most accurate method?
Let me show you. I'll just go back here. I don't know if you can see this well enough, but for me, it's just wall to wall. The aorta, you know, we're outer to outer, but that for me, for what I've read, it's just wall to wall. I don't know if you can tell the cursors, that's actually right there at the wall.
Mm-hmm. Great. And then one last question for now. Can you touch on the posterior arch vein? Does a true posterior arch have to have 3 connecting perforators?
I honestly, I'm not sure. I don't know if it has to have that. Let's see. I know our perforators are right here. I don't know, Malka. I don't know if it's a requirement to call it a posterior arch vein, that we have to visualize the perforators. I'm not sure about that.
Okay, thank you. And when we distal augment during the venous insufficiency study, should we be waiting a certain amount of time before moving on to the next area? Do we take venous refill time into consideration?
I'm sorry, can you?
I will repeat the question.
Yeah.
When we distal augment during
Yes.
the venous insufficiency study,
Mhm.
should we be waiting a certain amount of time before moving on to the next area? Do we take venous refill time into consideration?
So yes, absolutely. Absolutely, because you're not going to get a good augmentation if you're constantly augmenting, right? So there definitely is a consideration for venous refill time. um, in the saphenous system as well as the deep system. When I'm evaluating, I squeeze very slowly, kind of like I've heard it referred to as a siphon technique, squeeze very slowly. And I'm actively sampling and I'm watching for it to return back to normal, whether it's no flow at all or a little bit of phasic flow, depending on where I'm at. And then I move on. It really is pretty quickly, and also consider when you're evaluating the superficial system, you're doing your AP diameter measurement, then you're turning in sag and you're doing your color with your waveform. And so you're squeezing to get your good waveform and assess for reflux. And then you move to your next location. And then you're doing your transverse, your AP diameter. So by the time you work through those next few images, it's ready to augment again, typically.
Great, thank you.
Any other questions?
Not for now. We'll leave the rest for the end.
Okay. All right. So there's lots of different treatments, but in the interest of time, it's just 90 minutes. We'll talk about the role of ultrasound with treatments, primarily with ablation. We can use heat and chemical ablation. Today, I'm going to talk a little bit about just the heat ablation. Ablation is defined as the destruction of one's body part. That's the definition of ablation. And what we are doing is using heat to destroy the saphenous vein. So incompetent greater saphenous contributes to varicose veins. Therefore, ablation of this vessel is usually a successful treatment for these patients that are suffering from venous insufficiency. Venous ablation uses heat energy to close off the diseased vein. When the diseased vein is closed off, blood remains in the deep system, moving the blood back towards the heart through the deep system with the help of the calf muscle pump and the valves, instead of flowing back out through into the saphenous. So this is, definitely, patients within days have improved symptoms with the ablation treatment. Our role for ultrasound, typically, it's kind of a phased approach with ultrasound. We first are scanning for the diagnosis. So we see our patients, we're evaluating them for DVT, and then we're evaluating the superficial system for insufficiency, and then they go home. So, and we document all of our findings and we submit to the reading physician. The reading physician determines whether or not it's something that can be treated with, he or she can treat with ablation. And then the patient will come back. So then the patient's scheduled, the information is submitted to the insurance company's approval with our largest diameter measurements, and our greatest reflux time is all submitted, and as well as the symptoms for the patient, because the insurance companies consider the symptoms, and then it's approved and the patient is scheduled. So the patient comes in and it's a minimally invasive procedure that is with ultrasound guidance. We do not use sedation for these procedures. It can be performed in the doctor's office. It is a sterile approach. We do practice sterile technique because we are entering into the venous system and inserting a catheter into the venous system. So we certainly practice sterile technique, but we don't use sedation. We just use a local anesthetic for the patient's comfort. And we use ultrasound to guide the catheter placement into the superficial vein. And we're, before we start, the patient is prepped and ready on the table. And before we even insert the catheter, as we see here, we are quickly just scanning one more time, scanning through the area, because it could be a different technologist doing the procedure, or you're just not going to remember the patient's anatomy and the course of their vessel and how it navigates through. So we scan again to get an idea for, okay, where's the vessel in relation to the surface of the skin? Where is the bifurcation, femoral bifurcation or confluence? Where is this junction? Where's the saphenous vein draining into the common femoral vein? Because you want to have all this information so that you can support your provider as they insert the catheter and navigate it up towards the groin, and the junction. And with the catheter, you advance the catheter through the superficial system. Once it's placed, we back it out towards this area here and use the heat to treat the vein. The tissue, there is some fluid injected into the surrounding tissue, so the surrounding tissue doesn't feel the heat to treat the vein. And it's pretty quick. This procedure itself is about 30 to 40 minutes, depending on the patient and any complaints, but we withdraw the catheter and treat and apply pressure, withdraw the catheter a little bit more, treat and apply pressure, and you just back down towards the leg, towards where we entered, and withdraw the catheter. With ultrasound guidance, of course, we are following. Very important to see the tip of the catheter in relation to the common femoral vein. Typically, the literature seems to vary, but typically 2 to 5 centimeters from the saphenous femoral junction is where they want to start treating. So the providers want to see the femoral vein, the saphenous, the junction, and the tip. And in this vein here, very easy to see here, right? The vein's nice and dilated, but here the vein has started to spasm a little bit, and that can make it a little bit more difficult, certainly when the vein is spasming in response to the catheter placement. So, and very important to identify the tip. In fact, the providers will not start the procedure until a tip is identified.